Here is our TFCC tear and a ringette player injury presentation by Larissa, Callista, Megan, and Olivia. TFCC, or triangular fibrocartilage complex, is an intricate system of ligaments and cartilage on the ulnar aspect of the wrist. It is primarily responsible for the stabilization of the distal radial ulnar joint, but also plays a large role in load bearing, as 20% of axial loads through the forearm are transmitted through the ulna and absorbed by the TFC. Unfortunately, due to the expansive nature and roles of the complex as a result of its numerous components, injuries to the structure are quite common in sport. When the TFCC sustains a tear to any of its components, symptoms such as palpatory pain along the ulnar aspect of the wrist, clicking of the wrist during rotation, and pain with most movements or joint loadings will be present. Components of this complex include the triangle fibrocartilage, or TFC, the meniscus homologue, the ulnar collateral ligament, dorsal and palmar distal radial ulnar ligaments, ulno-lunate and ulno-triquetral ligaments, and the extensor carpi ulnaris, or ECU, tendon sheath. With ringette being very similar to hockey, but unlike hockey in the sense that a stick is straight and a rubber ring is used instead of a puck, the rules of ringette make it wide open sport, with an emphasis on playmaking and ring handling skills. As ring handling techniques completely rely on all planes of wrist motion, it is extremely evident that proper wrist joint mechanics and the health and functioning of the TFCC is an essential factor to performance. The most common mechanism of injury occurs when the wrist is in an ulnar deviated position and an axial load is applied, such as experienced when falling on an outstretched hand or fouche injury. In addition to this, excessive wrist motions in extension, supination, pronation, radial deviation, and ulnar deviation, such as those experienced when an individual is using a racket, bat, golf club, or hockey stick, can also damage various structures of the TFCC. Here's a great example of that fouche injury with ulnar deviation, and you can imagine here how the TFC gets compressed in this incident. In this image, the red circle, we can see it in ringette, especially how that axial load of ulnar deviation can repetitively occur in shooting and passing and stick handling. I also highlighted all the other numerous wrist positions being demonstrated in the sport with the blue circles. The goal of the supportive taping technique will be to reduce or limit motion at the distal radial ulnar joint, offload the TFC, and prevent separation of the radius and ulna. For this taping technique, the following supplies will be required: spray adherent, scissors, and then either Hypafix, Tear Elastic, or Powerflex, and either Leukotape or zinc oxide, depending on the level of support wanted. The taping technique will begin with an assessment and inspection of the area to ensure it is appropriate to tape. Therapists look for any deformities, contusions, abrasions, penetrations, lacerations, tenderness, burns, swelling, heat, altered function, redness, or pain, and will assess pulse, motor, and sensation. After clearing the athlete of any contraindications to tape or tape adherent spray, the therapist will use an alcohol swab to clean off any oil, sweat, and debris. The athlete will be positioned sitting upright or laying supine on a table, and the therapist will begin by spraying the entirety of the wrist region with tape adherent spray. This will be followed by laying down a piece of Hypafix approximately 3 inches wide that extends above and below the distal radial ulnar joint. The Hypafix should be applied with no tension, as it is not there to provide support, but to rather be an anchor and barrier for subsequent Leukotape. Next, the therapist will apply an approximation compression tab, or AC tab. The AC tab is a strip of Leukotape about 4 inches long that is pinched in the middle, thus creating sticky tabs on both sides. It is applied over top the TFCC on the dorsal aspect of the ulna, and the therapist will now encircle the wrist with Leukotape. To be specific, the therapist will start on the palmar aspect of the ulna and pull with tension from the lateral to medial direction around the wrist. Once the strip of Leukotape reaches the lateral aspect of the radius, the tension can be released and the tape can be laid down. Following this, a second AC tab will be applied on the lateral side of the radius, and the opposite tensioning of Leukotape will be completed. To be specific, the Leukotape will be pulled from the medial to lateral direction, beginning on the dorsal aspect of the radius. Once the Leukotape reaches the lateral aspect of the ulna, tension can again be released and the tape laid down. Recheck PMS, and that should complete the tape job. It is important to understand that support taping techniques is intended to reduce the athlete's pain by limiting, not restricting, movement distal radial ulnar joint. As a result, communication with the athlete to ensure that the tape is applied in a comfortable and non-restrictive manner is essential. To prevent skin irritation, ensure that there is a base layer such as Hypafix covering the area to avoid direct contact with Leukotape. In addition, ensure that the Hypafix is applied flush to the skin without wrinkles and windows. Next, in order to ensure that the tape is not applied too tightly around the wrist, check distal pulse prior to and following taping procedures. During application, ensure that you are applying an even amount of force when pulling leukostrips towards the radius and ulna. And lastly, as always, communicate with the athlete on how the tape feels to them and have them test the support and comfort with proper return to play testing protocols. For listening to our presentation, any questions?